Welcome everybody to the Institute for Life Course and Aging. On the behalf of our director, Dr. Lynn McDonald, who was here a moment ago, we welcome you. This is the last seminar we have in the series for this year. So we are very pleased to have with us Dr. Kenneth Shulman from Sunnybrook and U of T. And actually, Dr. Shulman is a graduate of the Faculty of Medicine here at the University of Toronto. He is currently Psychiatrist-in-Chief at Sunnybrook and Professor in the Department of Psychiatry at the University of Toronto. And he's also the inaugural Richard Leward Chair in
Geriatric Psychiatry.
Thank you. In Geriatric Psychiatry at Sunnybrook and U of T. So we are very pleased that he could be here. He's been recognized by the IPA, which is the International Psychiatric Association, as well as the Canadian Academy of Geriatric Psychiatry, and he's been elected to the American Psychiatric Association as a fellow. So we're very pleased to get with us today to speak about early detection. And thank you, Dr. Shulman.
Thank you very much. Well, it's a pleasure to be here and have a nice intimate group to interact with. Maybe I will sit down and get out of your way, I guess. Can everybody still see me and hear me? Yeah, I'm very pleased to be here. Just a slight correction in the introduction, which actually is relevant to the topic. I used to be the Psychiatrist-in-Chief at Sunnybrook. I was for 10 years. I'm based in the Department of Psychiatry, and I'm trained as a psychiatrist, and my specialty is geriatric psychiatry. But I've evolved a little bit over the years, and really as a function of the work that I do in geriatric psychiatry. And my role now is, at Sunnybrook at least, is the program chief for a program, and we have programs at Sunnybrook. Many hospitals have program structure that tries to bring together the traditional medical department structure, because the medical departments, as they're constructed and as the Faculty of Medicine is organized around, don't necessarily make the best organizational structure to meet the needs of our patient population. Our patients don't fit so readily into traditional departments of psychiatry, neurology, medicine. Needs of people, especially with dementia that I'm going to talk about today, are quite varied, and you need a system that can bring together multiple departments and expertise and resources. So I'm the head of a program called the Brain Sciences Program. And I'm a psychiatrist. I'm the chief of that program, and that program includes neurologists, it includes neurosurgeons, it includes geriatricians, neuroimaging people, neuropathologists, neuropsychologists, all the neuros you want. But it's a different way of approaching disorders of the brain and mind than the traditional. And one of the reasons, as you'll see, is that dementia is an example of a disease, a disorder, that doesn't respect the traditional brain. Who's responsible for dementia? I mean, is it geriatric medicine? Is it psychiatry? Is it neurology? Is it the family physician? Long-term care physician? Well, the answer is all of the above. And how people get into the system is an interesting issue. Anyway, we could talk a little bit more about that, but your little slip up there allowed me to give some background, which I think is relevant to this topic. So I thought I would talk to you today about the challenge of early detection of dementia. I'm going to use Alzheimer's disease as the kind of paradigm for that. Alzheimer's disease is only one of a number of dementias. It's the one that accounts for the greatest proportion. 50 to 60% of all dementias are of the Alzheimer type, but that leaves 40 to 50% that aren't. So it's very much a heterogeneous condition. And I'm talking about, I titled it Promises and Practicalities. So there are a lot of understandable hopes and promises about dementia and finding a cure and treating it. Because we're all desperate. This is a terrible disease. It affects a lot of people, but we have to be practical. So here's my talk. I'm going to talk to you a little bit I know this is not primarily a medical audience, but I'm going to talk a little bit about the basic science of dementia with a focus on Alzheimer's disease, so you can understand where we're heading in terms of trying to detect this disease early. You have to understand the pathology if you're going to understand how we're going to detect the disease, and that includes the use of biomarkers. I'm going to talk about the interesting relationship between mood disorders and dementia. So I'm a psychiatrist, and psychiatrists deal with mood disorders, but there's a very interesting relationship between mood disorders and dementia, which I'll talk about. And then I'm going to talk about cognitive screening and just a little bit about the future. So that's the plan for the next maybe 45 minutes to 50 minutes. So something you guys all know, and of course on Life Course in Aging, you know that Alzheimer's disease is, dementia really, is increases with age. And it's not until you get into the 85 and over age group that it gets to be a very significant prevalence. The idea, and you know, also let me just tell you a bias I have right off the bat, and I'm not sure how you'll take this in the Life Course on Aging. You have a course that's devoted to aging, but I think our definitions of aging and geriatric especially have to change. When I started in my own training, which back in November 1978, I came here. I was just part of the new exciting aging phenomenon going on here. But you know, when I started training, there were papers on geriatrics that were 55 and over, which we laugh at now. But you know, so subsequently we went to 60 and over. Then the accepted definition of geriatric became 65. So geriatric services like ours, geriatric psychiatry, we would take everybody age 65 and over. Now, especially as I approach that age myself, I'm not happy about that being geriatric. I mean, there are so many good examples of people who are 85 and who are not geriatric. The average 65-year-old today is nowhere near a geriatric. It is middle age. The average 75-year-old is middle age today. I think if we were going to talk about a geriatric cohort, with exceptions, there's some 90-year-olds who are not geriatric. As a cohort, I would say 85 and over is really the geriatric cohort of today. Anything younger than that is late middle age.
I love it. Thank you so much.
And I'm not doing that to flatter people or to bolster my own self-esteem. If the definition of geriatric is anything to do with frailty or cognitive impairment, then you have to use 85. Because the average 75-year-old, even the average 80-year-old, is independent, healthy, not suffering, not frail. And so, but you can see that Alzheimer's relates to that. It doesn't, until you get 65 to 74, it's a negligible prevalence of dementia. I mean, we see, I'm going to see next week, I'm going to see a 37-year-old man with frontotemporal dementia. And I see some 50-year-olds, 60-year-olds, but most people with dementia are in that age group. So it's definitely a function of aging. And of course, from a life course perspective, from a societal perspective, the reason this is critically important is that that group of people, the 85 and over population, is the fastest growing segment in our society. Therefore, the prevalence of dementia and Alzheimer's disease is going to increase accordingly. We're facing a major challenge. And one could argue, based on all of the things we know about the effects of Alzheimer and other dementias, it is arguably the greatest public health challenge that we will face in the next generation, the challenge of dementia. So that's the answer to the question, why is it important? I'm going to just talk a little bit about this, what I call the dementia cascade. And to put this in perspective, by the time we diagnose dementia, especially Alzheimer's disease, the evidence, the neurobiological evidence, is that that process that leads to a clinically significant dementia has been going on for at least 15, 20, maybe even 30 or more years. It is a process that begins much earlier, but doesn't manifest itself clinically until many years later. That's important. People who have high IQ, people who use their brains a lot in life, have a certain amount of reserve, and they may manifest their disease later, but it begins early on. So it's that's why I've used the term prodrome. There is a period of time, 10, 20 years maybe, we don't know exactly, but there's evidence that it's where the disease is silent clinically, and yet it's going on. If we could detect that disease before it becomes clinically manifest, that would be a tremendous development. And so early detection, it's asking a lot, but we're looking at that. That's an important development. So that there's a period of a long time, and then you develop conditions that we call SCI and MCI. SCI is subjective cognitive impairment. MCI is mild cognitive impairment. So we know that there are people, I'm sure most of us in this room, and I for one lately have been saying that myself, I notice that my memory is not as good as it used to be. And I bet that's true of most people my age and older. So the question is, at what point does it become a concern great enough that you actually go to a physician or to someone and complain about it, say, I think I have a problem. That's called subjective cognitive impairment. And where there's very little else, when there's no objective evidence of cognitive problems, we call it exactly that. It's subjective cognitive impairment. But what significance does that have? Well, we now know that a significant proportion of people who say that they have memory impairment will go on to develop further changes, more objective changes. In the early stages, we call MCI, or mild cognitive impairment. And mild cognitive impairment was known in the old days. Our friend, the Canadian psychiatrist Bertie Krall, many years ago, coined the term benign senescent forgetfulness. Right? Because they recognized it's not a new phenomenon. People knew that people were forgetful as they got older, but there were some people who were forgetful, but it was benign. It didn't mean that they were going to develop Alzheimer's disease. They just had forgetfulness. So he distinguished between the malignant forgetfulness of Alzheimer's disease, where you're going to go on to develop a degenerative brain disorder, from those who had benign forgetfulness. We now use the term mild cognitive impairment, because we also know now that a certain proportion of people with what was called benign forgetfulness or mild cognitive impairment will in fact go on to develop Alzheimer's disease. It's predicting which of those individuals will develop dementia that is the challenge, and an important challenge. Again, can we know? I mean, if you think about it ethically and from a psychological perspective, do people want to know if you're going to develop? It's like having, the Huntington's gene. It's an ethical dilemma. Actually, I just noticed in the paper today, the guy who discovered the prediction for Huntington's is Michael Hayden from BC. He's getting a Gardner Award here in Toronto very soon. But nobody's yet discovered how to predict Alzheimer's disease. I'm going to talk a little bit about that today. But we're not quite there yet. So then we go on to develop early dementia, and then it goes on to severe dementia. And the way I've set this up is I've divided the screen, you see, into two halves. On the left side, we're looking for cure. And that's before, really, in the very early stages, maybe it's realistic to have a cure. Can we find a cure? That's what everybody wishes for. In order to cure Alzheimer's disease, we're going to have to identify it before it even becomes manifest, or at its very early stages. Once you develop dementia that's diagnosed clinically, we're not looking at cure anymore. It's going to be very unrealistic to think we can cure a disease that's already been going on for 20, 30 years silently and then finally has manifested itself, the brain's already deteriorated. Then we're looking at care. Not that care is unimportant, but we're looking at care. The drugs we have today, which are called cognitive enhancers, only work in the early stages of dementia and in the later stages of dementia. And at best, I've illustrated that they try to slow down that inexorable progression from the early stages of dementia to the severe stages. But right now, there is no way of preventing that from happening. People who have Alzheimer's disease today will progress, if they live long enough, to have a severe dementia, no matter what drugs we give them. But the drugs do, in some people, slow the process down, improve it temporarily at best, but it's basically a superficial treatment. What we really want are anti-dementia drugs, the drugs that will prevent the disease from progressing altogether and prevent it from even manifesting itself. So to go back up the cascade, if we're going to get people early, we either have to develop biomarkers, I'll tell you more about what biomarkers are, to identify the disease early, or screen people in primary care settings for the earliest stages of cognitive impairment.
Can I ask a question? Could you go back then?
Yeah.
What do you consider a valid cognitive screening measurement?
I'm going to talk about that.
Oh, thanks, okay. 'Cause
That's built
confusion out
in.
there.
I am going to talk about
Thanks,
cognitive
okay.
screening.
Okay, thank you.
So the pathology, well, you know, you guys are not necessarily have to know the details of the science, but you should know, really everybody should know what Alzheimer's disease is pathologically. Even lay people should know that, right? So Alzheimer's disease is a degenerative brain disease. And the gross pathology, the core pathology, consists of three pathological phenomena. What are called plaques, neuritic plaques, which consist of extracellular deposits of amyloid. So amyloid is the substance that and I'll tell you more about amyloid. Amyloid plaques are present in a much higher frequency in the brains of Alzheimer's disease patients. Almost everybody will have a little bit of amyloid plaque, but Alzheimer's is amyloid, and also known therefore as an amyloidopathy. Rosemary's here. Rosemary, you could give this lecture for God's sake. What are you doing here?
Too much to be interested. Oh,
Rosemary Meyer, a well-known geriatric psychiatrist. The second pathological finding is are called neurofibrillary tangles, and these are a form of protein called tau protein. And the particular, what happens, and I'll show you this in a minute, is that these are hyperphosphorylated tau proteins which lead to twisted filaments, and that's why they're called tangles. And the reason that the tau protein is important in the brain is it stabilizes microtubules, stabilizes the brain. When you get hyperphosphorylated tau, it destabilizes those tubules, you get fragments. And also the thing that we know, that everybody knows about Alzheimer's and dementia, is you get brain atrophy, loss of the neurons and synapses, which leads to brain atrophy, which you can see on a CT scan. So that's Alzheimer's disease. You know, before I went into geriatric psychiatry, and Rosemary did, people used to talk about dementia as hardening of the arteries. That's what most people knew, right? Probably even today. You know, senility, which just means old age, was associated with hardening of the arteries, atherosclerotic changes. Well, we then discovered that Alzheimer's disease was in fact related to these neurodegenerative changes. But you know, what goes around comes around. We now believe there is mounting evidence that there is a vascular component to Alzheimer's disease. So it's not so straightforward. And it may be, in fact, the most common form of dementia is a mixed type of dementia, which is both vascular and degenerative, neurodegenerative. So here's the basic science. You start with an amyloid precursor protein. It's broken down by enzymes known as secretase enzymes, and those enzymes break down this protein into a peptide called A-beta peptide, 142 A-beta peptide, and that is the substance that forms these amyloid plaques. That's the real pathology, right? And this A-beta peptide is what we're concerned about. That's the amyloid precursor. Then the tau protein, I told you, is related to these phosphate molecules hyperphosphorylate the tau protein, and they produce these tangles. There are enzymes involved, which are not really that relevant. I'm not going to talk about that today. I think there are more interesting things for us to talk about. Now, here I told you MCI, mild cognitive impairment, is a prodrome of Alzheimer's disease. You know, I go back to when I started. You know, in the old days, when I began, I was taught by my teachers, who I respected very much, and who were great teachers, that I was telling you there were many dictums that I learned. And one dictum was, when a patient comes into your office and says, "Doc, my memory's shot and I'm sure I've got Alzheimer's disease," we knew that they didn't have Alzheimer's disease. They were depressed until proven otherwise. Because many people with depression become excessively concerned about disease, and so we thought when people complain about memory, it's probably depression. And when a patient comes into your office and says, "Doc, there's nothing wrong with me," anybody who says that has Alzheimer's disease. Right? And that one I believe is still true. You know, if a patient comes to my office and says, "Doc, there's nothing wrong with me,"
what's he doing there?
Yeah, then they've got a problem. So there you go. But mild cognitive impairment is defined as either a self-report or an informant report of impaired cognition, and it's characterized by either episodic memory impairment or another cognitive impairment. There are different types of MCI. The most predictive of Alzheimer's is the amnestic form. Those people where the main cognitive impairment is memory, as opposed to functioning at the beginning, actually they're the ones who are most likely. So these people with subjective cognitive impairment or reported by an informant. So I've talked about the informant. The informants, of course, we know that, goes without saying, that the caregivers are very critical to this whole discussion. Because the caregivers, are important for information. If you're a physician, and you saw an older person and you didn't talk to the caregiver, you could be missing out on very significant problems. So every new consultation, I insist that a family member or a caregiver or a friend come along so I can get an objective report as well. And by definition, if you have mild cognitive impairment, you have minimal impairment in your activities of daily living, right? So this is the mild stage, and we consider it a prodrome. What percentage of people with MCI develop Alzheimer's is under discussion. There was some early reports as many as 15% of everyone annually will go on to develop dementia. I think that's probably a little high. So let's talk about biomarkers. So if we're going to detect this disease before it becomes clinically manifest, or very early, we need biomarkers. So what's an ideal biomarker? A biomarker is something that will detect one of the fundamental features of Alzheimer's disease. And we've already talked about the fundamental features, right? They are, what are the three fundamental features? Who remembers? Everybody in this room forgot already? I'm going to do cognitive screening on all of you. What are the three core features of Alzheimer's disease?
Memory loss?
No, the pathological features. I said the core pathology. Plaques.
Loss of synapses.
Loss of synapses and tangles. Beautiful. All right, you finally woke up. Maybe you have a sleep problem. Okay, so the idea of a biomarker is it should pick up these plaques, pick up these tangles, pick up atrophy early on. Can we do that? And we should validate them in neuropathologically confirmed cases. So when you know somebody's got Alzheimer's, the biomarker should correlate. It should be, ideally, it should be early in the course. In the ideal world, it should be before it's even clinically manifest. It should be able to distinguish the types of dementias. And ideally, a biomarker should be non-invasive, simple, and inexpensive, it's going to be practical. So that's what we're looking for. What do we got? Well, right now we can actually do cerebrospinal fluid taps, and there is a way of predicting who will go on from MCI, from mild to Alzheimer's disease, by looking at proteins and amyloid in the cerebrospinal fluid. Now, this is still not a practical test because you don't want to do cerebrospinal taps on people as a screening method. But it's interesting that if you find higher tau, higher phosphorylated tau, and actually less amyloid in the CSF, less amyloid because it's being deposited in the brain and there's less in the CSF, so it's a paradox. We have higher tau protein, less amyloid. That predicts who's going to go on, more likely to go on from MCI to Alzheimer's, but it's not yet a practical screen. We have imaging, and I'll show you some imaging that can predict who's going to develop Alzheimer's. So Alzheimer's develops at the beginning in the area of the brain called the hippocampus, and also in the medial temporal lobe. And you can see here, you can see behind me, on the left an Alzheimer brain and on the right a normal control. And you can see where we've pointed to the medial, this is the medial temporal lobe, and you can see how thin it is in Alzheimer's disease compared to the thickness, the 14 millimeter thickness of the medial temporal lobe in a healthy control. So that's where the disease starts. And can we pick it up early? And then here we've got very recently in Pittsburgh, they developed a compound known as the Pittsburgh compound, which lights up amyloid in the brain using the PET scanner. So on the top are healthy controls, and that's what your brain looks like in a normal PET scan, and with this ligand that attaches to amyloid. And you can see in Alzheimer's disease it lights up yellow. So the Alzheimer brain, we can light it up on PET scanning. So this is likely to become more and more useful. Now you still have to be fairly advanced in the disease to get this picture, but that's called the Pittsburgh compound. So imaging is another biomarker that we have. There's, I won't go into this entorhinal cortex. Now let's talk a little bit about this relationship of mood and dementia. Another thing I was taught when I started in psychiatry is that the reason that geriatric psychiatrists were really useful in society is that we could diagnose conditions in old people. We could tell the difference between depression, delirium, and dementia, the 3 Ds. And why was that important? Well, they were 3 different conditions, and they had different outcomes and different management and different predictors of decline. Depression, delirium, and dementia, 3 distinct conditions, and geriatric psychiatrists could differentiate them. Well, it turns out that these diseases aren't so separate as we once thought, unfortunately. And this is a study going back into the mid-90s. The first really major study that showed that depression was perhaps a risk factor for dementia. People who suffered from depression, and this is a study that didn't even look at clinical depression. They took, this is a survival analysis, cumulative study going forward 4 years, 50 months. They took a group in New York of healthy elderly people. None of them had dementia. They were screened. None of them had dementia. They were basically healthy people. The only thing they did was they surveyed their mood, and they divided this group of healthy elderly people into those that reported depressed mood and those that didn't. That was the one variable they wanted to look at. And over time, you can see in the survival analysis, this is cumulative survival until they develop an actual dementia. If you were depressed compared to the non-depressed group, you developed dementia at a much higher rate. Suddenly there became concern that depression is a risk factor for dementia. And this is a study, again, back in the 90s. There was another reason that geriatric psychiatrists were valued, is we could diagnose a condition called pseudodementia. So pseudodementia was actually a disorder where a patient with severe depression would come into the hospital, And their depression was so severe that they were disrupted cognitively, and they actually looked like they were demented, and sometimes they were misdiagnosed as demented. But when you treated their severe depression, the cognitive impairment improved. So, we covered ourselves. We said, oh, this wasn't real. We made a mistake, we said they were demented, but they were really depressed. So therefore, it was a pseudo-dementia. It was a false dementia. But George Alexopoulos in New York followed two groups of people. The ones in the broken lines were the ones with this reversible dementia, or so-called pseudo-dementia. And the ones in the solid line were inpatients who had depression without dementia. And they followed them forward, and again, over about 48 months, 4 years. Over the first 3 years, nothing much happened in terms of ultimately developing dementia. That was the end point of interest. But after about 3 years, suddenly a significant thing started to happen. These people in the broken line, the pseudo-dementia patients, the majority of them started to develop irreversible dementia. And even the ones without pseudo-dementia started to dement. So again, there was a concern. Maybe severe depression is a risk factor for dementia. And that pseudo-dementia that we said was pseudo, if we really thought about it, is actually pseudo-dementia, because it's the real thing. So there's the concern. There's other evidence from epidemiology that depression, here you can see, is a greater risk factor for developing dementia on readmission compared to diabetes, arthritis, and even mania. Now that's interesting, that depression is a greater risk for dementia than mania, which is a mood disorder. And it's an interesting finding. I don't have time to go into the details, but one of the speculations as to why mania is still, you get higher level of dementia with mania than some other medical conditions. But the reason it might not be as bad as depression, some people think, is related to one of the treatments for mania. So do we know what's the mainstream treatment for bipolar disorder? Lithium. And there's evidence that lithium may have neuroprotective properties. So it may be that that's why. Anyway, that's an interesting, I won't go into the details of that now. So I hear we're interested in screening, right? All right, so let's talk about screening. So another way, one way to detect dementia early is through biomarkers, lighting up the brain, markers in the blood, markers in the CSF. We're getting there. We're not quite there. Probably from a practical point of view, the best way to find dementia early is to do what we call cognitive screening, brief screening tests. So now, in the true sense, screening, well, we'll talk a little bit more about that. So cognitive screening. And the argument for early detection goes as follows. Why do we even bother if dementia is a progressive, irreversible condition? What's the point of diagnosing it early? And there's a genuine debate about that point. But a lot of people make the following case, including myself. That is, the value of early detection is, first of all, to explain both to the person and their family why there's been a change in their functioning or in their well-being. Something's happened. To ignore that and let people struggle on is a problem. Because very often, another dictum, let me give you more dictums. When a family member comes in and tells me that there's something wrong with their relative, as far as I'm concerned, they're always right. There's something wrong. When they give you their explanation for what's wrong, they're very often wrong. Most commonly, family members misattribute early signs of dementia for depression, and even clinicians will do that. So it's very important that you explain what's going on, both in terms of treatment and an explanation to the family. Then, if you do diagnose Alzheimer's or dementia early on, the individual and the family have an opportunity to plan living will, powers of attorney, get your finances in order if you know that you're going to have a progressive disease. So, the other reason is that people with dementia, and even early dementia, are at greater risk than the average person for delirium, for driving problems. That's a whole other area. Should people with dementia, even early dementia, be driving? We now have drugs, cognitive enhancers, modest benefit, but still it's worth trying them early in the course of the dementia. By the way, I should mention that these drugs are of no value in the in mild cognitive impairment. There is no point in taking cognitive enhancers before you actually develop dementia. You cannot prevent the dementia from occurring. All you can do is slow it down once it has occurred. Until, if we ever develop these anti-dementia drugs, then there will be even greater motivation. And from a societal point of view, if we can prevent some of the complications of dementia, prevent admissions to hospital, prevent early admissions to nursing home, we may be able to save money. And so there's an economic case. So, screening or not screening? Well, first of all, the screening is different than diagnosis. So let's be clear about that. There's no Alzheimer test. You make the diagnosis of Alzheimer's disease on the basis of history and really ruling out other conditions. And when we talk about cognitive screening, I'm really not talking about it in the true epidemiologic sense of screening, because screening in the epidemiologic sense means testing people who are completely asymptomatic and looking for the disease, right? So mammograms, in all women over 50, whatever our policy is now, is true screening. That is, everybody over 50 should be screened, and whether they have a complaint or not. But there's no evidence that that's going to be of benefit with dementia. You can't screen everybody. Nobody is recommending that. Rather, we're really talking about opportunistic case finding. People who have complaints of some type should be screened at that point. And the kind of cases that should be screened are people who have subjective cognitive impairment, the risk factors for dementia. Those with mild impairment should get regular screening. Those with mood disorders should be regularly screened. Those with a family history, those with a history of delirium or head injury, because those are risk factors for dementia. And also people who have significant vascular risk factors, because vascular brain disease will produce dementia too. What we do know now, I think it's fair to say, is that any insult to the brain makes you at greater risk for dementia. And we define insult that includes psychiatric disorders. People who have depression, other psychiatric disorders are probably at greater risk for developing a degenerative condition. So in this higher risk group, it certainly is worth screening people with cognitive screening tests. We know that this generally doesn't happen in general practice, and the main reason is GPs complain they don't have time, and the other thing is they're worried that they're going to offend their patients. And the irony is that the very patient who is most at risk and probably is impaired is the one to object the most to screening. So when people complain, and get upset, that's often, but it's a problem. So we have a challenge. We don't have time in primary care, and we don't want to offend the patient. So we need screening tests that don't take a lot of time and that don't offend the patient. That's what we're looking for, ideally, right? The one screening test that everybody knows, has everybody heard of the mini mental state exam? How many people in this room have actually heard of the mini mental state exam? Most people? It's the most widely used all over the world. If you go to China, if you go to Asia, if you go to Europe, you go to South America, everybody knows this. It's an amazing phenomenon, this test, developed by Marshall Folstein in 1975. He sort of did it on the fly. He was looking for a test in hospitals to look for dementia. But the mini mental state is what I call the lingua franca of cognitive impairment, meaning the common language. If you want to have a quick report of somebody's cognitive state, you say, oh, he's got a mini mental of 14 or a mini-mental of 28. It means something to people today. It's out of 30. But there are problems with this mini-mental state. First of all, it's 1975. It's almost 40 years old. And it's still, everybody still uses it. So much so that it's almost malpractice not to use it. We got stuck on the mini-mental state for some reason. The whole medical world was imprinted like Lorenz's goslings on the mini-mental state. And that's all they know. They won't shift to better tests. There are better tests out there. There are problems. There's an effective age. You can see that with age, normal aging, the mini-mental state goes down. So the average 90-year-old is not going to score as well as the average 75-year-old. Doesn't mean that they're dementing or that there's a concern. Education is a bias. People with very limited education will look worse. That's true of all screening tests, but especially the mini-mental state, which is heavily weighted towards language. And if English isn't your native language, then it's a problem. There are lots of problems. It takes too long. Even 10 minutes, which it is, I said 5 to 10. It's closer to 10 minutes in the average per. I can do a mini-mental state quicker, but most people would take 10 minutes, right? A lot of false negatives. People with high IQ. You know, many of our teachers are professors at the University of Toronto who develop dementia. They come to us and they score 20. I won't say what Mary Jo would score on a test, but she'd probably score 29, even if she had dementia. The professors do well because they've got reserve, but they're dementing. That's a false negative. Interestingly, it does not test executive or frontal functions. That's a whole area of brain functioning that this screening test is missing. And if you want a screening test, it should be a wide net. It should cast a wide net. It doesn't. And then there's the big public health problem of orthopedic problems associated with how can a cognitive screening test have orthopedic problems? Is that possible? You know why?
Why?
Because if you know the mini-mental state, one of the tests, and Folstein, I told you, he didn't give a lot of thought to this. He just developed it one afternoon with his wife and another guy by the name of Q. He included a 3-stage command in the mini-mental. The 3-stage. You know what the 3-stage command is in the mini-mental state? You know what it is? What is it?
Take this piece of paper in your right hand, put it on the floor, pick it up, and then ask them to pick it up.
Right. That's exactly it. Take this paper in your right hand. You left out folded in half. That's part of it. It's a 3-step.
Yeah.
Take the piece of paper, fold it in half, put it on the floor. That's a 3-step command. Now, I was sitting with Marshall Folstein at a meeting once. He was sitting right beside me. I said, "Marshall, why did you say put it on the floor on a 3-step command?" He said, "I don't know. You know, that was the way we always did it." So look what happens when you do that. The patient has to bend over and put it on the floor. The doctor has to bend over and pick it up. And then they both have back pain. I did a calculation one day about how many mini-mental states were administered worldwide every day. And I did a sensitivity analysis. What percentage of those would have put their backs out trying to bend over? This is a serious public health problem. All right, so if we don't like the mini-mental state, what could be an ideal screening test? So an ideal screening test should be quick. We know GPs, frontline clinicians are busy. Ideally, I think it should be less than 2 minutes. Can we do a 2-minute screen? And it needs to be well tolerated. People don't get upset. It needs to be easy to administer and score. All the usual independent of culture, language education, all the psychometric properties that we look for in a screening test. Inter-rater reliability, test-retest, sensitivity, specificity. We want to minimize false positives, false negatives. And we want to cast a wide net. Can you do all that in 2 minutes? You don't think so? No? Never know. Might be possible. I think it is possible. As a screening test, not a remember, we're talking screening, not diagnosis, right? So let's remember that. All a screening test, a positive result on a screening test doesn't mean you have Alzheimer's or any other dementia. All it means is what? What does it mean if you have a positive screening test? What's that?
You need more tests.
You need more tests. You need more investigation. That's true. It's true of the mammogram. It's true of a lot of screening tests. It doesn't mean you got breast cancer because you have a positive mammogram, but you need to do more investigation. And that's exactly right for cognitive screening. So let me declare a bias. I've had an interest in clock drawing for a long time. I've tried to promote clock drawing. I even named a clock drawing test after myself, which reveals another disorder that I have. But there are a lot of clock drawers out there. It's become a cottage industry, actually. But clock drawing, if you think about it, it's one of the screening tests that's out there. I'm using it as an example because it doesn't take a lot of time to do the clock test, and I'll show you some. It's an example of a screening test. We used to think in the old days, again, back in the old days when I was starting, clock drawing was thought to be a test of visuospatial function, and therefore parietal lobe. So the original people to use clock drawing were neurologists. And neurologists, I don't want to disparage neurologists, but in the old days, neurologists until very recently had no interest really in cognition. Neurologists, until very recently, they only believed that brain lesions that affected motor and sensory function were the only things that were important. And as a result, anything that was sort of psychiatric was dismissed by the neurologists as what they called functional or supratentorial, above the tentorium, and it wasn't really very important or serious. The only thing that could be serious if you had a motor or sensory deficit. And that's why they thought about clock drawing not as a cognitive test, but as a test of parietal lobe functions. Maybe if you get a parietal lobe lesion, it might affect your visual spatial ability, and that's why clock drawing was used. But in fact, if you think about it, clock drawing involves a lot more than visual spatial testing. To draw a clock, you have to comprehend what a clock is. You have to understand the concept of time and representing time in an abstract way by symbols. So that's abstract frontal executive function. You have to be able to plan. When you're starting to do the numbers, you can't just write 1, 2, 3. You'll see examples. The people who can't plan ahead, the typical thing is they start doing 1, 2, 3, and crunch all the numbers, and then I hear, whoops, you didn't think ahead. It's because you need a good frontal lobe to think ahead. So it touches frontal executive. Visual memory, you have to remember what a clock looks like. So you have to have visual memory. You have to have visual spatial ability. You have to be motivated as well. If you're severely depressed, you can't be motivated. And then the last one is related to the task that we generally ask, which is when you draw the numbers, we say, set the time at 10 after 11. So the number 10, when you hear the 10, do you point to the number 10? No. What do you point to? 11 and 2. So you've got to suppress the urge. You hear the number 10. You actually have to point to the number 2, which is a symbolic, abstract representation of 10 minutes after the hour. That's abstracting. So this little test, clock drawing, is not just a visual spatial test of parietal function at all. In fact, it's a good screening test for all the reasons we just talked about. So there are, if you're interested in clock drawing, there are clock aficionados all over the world, and what's the best way to use the test? Should you have a pre-drawn circle or not? Anyway, this is generally the instruction I use. This is a clock face. You can try it on your friends and family. It's a very fun thing to do, and you'll pick up all sorts of impairment. You won't know what to make of it. Everybody, it'll be good for table discussion. People I know, they practice the clock test now before they come to see me. They're afraid.
That was my husband's recommendation, was preparation for aging.
Yeah, practice the clock test, God forbid. So clock face, fill in the numbers, and set the time to 10 past 1. So we don't use the word hands. You don't give them a clue. I'll show you why. So here's some examples. These are people who have mild impairment. On the top level, you see these are, as far as I'm concerned, that's a normal clock. The numbers are all there. They're more or less, in the right order and spaced out. And there are 2 hands, one at the 11, one at the 2. That's good enough for me. You can do that. You pass the screening test. On the second level, you'll see some mild you know, here's some people who use the border very well. This one, the planning wasn't so good, right? This one is micrographia there. Probably has Parkinson's disease. And then that one over there in the middle far left. If you look at that one, somebody said to me, that's somebody who's got obsessive compulsive disorder. You know, man, did they go to detail. But not only do they have obsessive compulsive disorder, but you see, very interestingly, this is upside down. So what they did was they actually rotated the paper. Right? They rotated. Anybody who does that has Alzheimer's disease until proven otherwise. You rotate the paper. But that's a mild level. And then here's these people who have trouble with 10 after 11. These are all the people who show this frontal pull to the 10. And it's really interesting because you can see how the damaged brain, you know, I know it's got something to do with 10 after 11. And one person wrote in the number 10 right here. That's very common. It's a sort of a literal concrete response. We're running out of time here. But I want to show you that the clock is sensitive to deterioration. This is a study we did where we followed people in the community, all of whom had dementia, Alzheimer's disease, and we tested them every 6 months. And you can see that patient 1, patient 2, patient 3, over time, all deteriorated terribly on the clock test. So it's sensitive to change. This one was diagnosed with dementia with a normal clock, which is still possible. And then by 6 months, they were already missing out. Anybody who leaves out that minute hand is dementing until proven otherwise.
What happens if they have a stroke and they can't, like, you know, they can't write it up? Do you know what I mean?
Well, if there's a physical reason
Yeah,
for that,
but
then you have to factor that in. You can't call them demented for physical
But how
reasons.
would you test them then if there was physical limitation?
Well, when you're examining, if somebody has, I mean, physical, they couldn't write,
Yeah.
well, then you'd have to test that as part of your exam. But we're assuming here that people can see and can write. That's the assumption. There's another bad mistake. Anybody who does Roman numerals, they're demented until proven otherwise. You believe me? No? Here's an example. Here's a case. A 75-year-old woman was referred to us with chronic headaches and a depression that wouldn't respond to treatment. Now that's already a concern. When somebody doesn't respond to treatment, the index of suspicion for a dementia goes up. And here's the clocks. This is a lady that we saw from March of 2000 until May of 2004. So starting at the top left, that's what her clock looked like at the initial exam. Now the history was that her mother had suffered from a dementia in her 60s and also complained of headaches as the first sign. And she had the same symptoms, but the clock is perfectly normal. She even drew a little heart in the middle, you know, a little decoration. It was all nice. But by November of that year, she was already starting to pull to the 10. And when we followed her over time, you can see there were actually fluctuations. And by 4 years later, she's severe. She's pretty much obviously demented. But at the beginning, it wasn't obvious. The clock picked up the changes over time. And very early on, we could see there was something happening. She was deteriorating. Yes?
So, from going back to your screener question, it looks as though you can have people who are dementing with perfect.
Yes, you can. That's right. There's not. That's why the clock as a screening test is not 100%. No screening test is 100%. So it would be a false negative.
But do you have a sense of like the proportion of false negatives
with the clock test? I can't give you an exact percentage, but there certainly are people in the very early stages who will have a perfectly intact clock. Then everybody asks me the question about digital clocks. You know what? We got an old generation doesn't know they're going to digital clocks. So two of my friends who are geriatricians, Mark Clarkfield and Howard Bergman, developed a scale that they modestly called the Clarkfield-Berman Cognitive Deterioration Scale. And they showed what would happen in the generation that was grown up on digital. So they're mild, they sort of perseverate a little at 10 after 4. Moderately impaired, the numbers fragment, and when they're severely impaired, they draw perfectly normal analog. So that's why I say people today who do Roman numerals are impaired, whereas in the future, the young generation, if they draw an analog clock, they will be impaired. That's a joke. So there are other screening tests. There's a test called the mini-cog, just so you're aware, because we're running out of time. I'll be happy to answer questions. The mini-cog is a combination of a memory test and the clock drawing test. So basically what you do, it's a two-step, you ask people you give them 3 items to recall. You say, I'm going to ask you in a couple minutes to remember these 3 objects. In the meantime, you get them to do the clock test. Then after they're finished the clock test, you ask them to remember the 3 items. So it's pretty straightforward. It meets the criteria of an ideal screening test. It's quick, simple. And this is Sue Borson in Seattle and her group have shown the following as a screen. They call it the mini-cog. The mini-cog. If you can't recall any items after a few minutes, you probably fall into the dementing category. If you can recall all 3 items, you probably, again, for screening purposes, not diagnostic, you're probably okay. If you can only remember 1 or 2 objects, whether you fall into the really concerning group, the demented group or the non-demented group, depends on the clock. So 2-item recall, a normal clock, you're probably okay. 2-item recall and an abnormal clock, you're probably impaired. So again, for screening purposes, this gives direction, and that's called the mini-cog. There are frontal lobe tasks that the mini-mental state doesn't test. I won't go into the details, but there are tests, and these tests, by and large, they involve generating words and verbal fluency, abstraction, and there's a whole series of tests that involve set shifting. So the damaged brain is a sticky brain, meaning that the damaged brain has trouble shifting sets, mental sets. It gets stuck. That's why we see perseveration, because of that. And one of the tests, we use tests that see how the brain can, so one of this is called the Luria. The Luria test is a 3-step test using fist, side, palm. Fifth, side, palm. I practice this a lot. And the demented person has trouble with that because they can't shift. It's hard to go back and forth. Anyway, there's another test called the Trailmaker. We now have a Canadian test called the Montreal Cognitive, which is a test for mild cognitive impairment because it's a little harder than the mini-mental state. I won't go into the details. In 2000, I need to update this. You can see it's 2011. It was my first talk in 2011. I just change the year every year. But to me, an ideal screen would be a brief memory test, clock drawing, verbal fluency in terms of generating words that begin with a certain letter. I put the mini-mental state in here only because it's still prevalent and we're stuck on it. But I really don't think it's the best test. And don't forget asking the informant, the caregivers. Right? So we'll just end. So this was 2009. I have to update this slide too. I put 1978 down because that was the year I became a psychiatrist, a geriatric psychiatrist. And I was taught a lot of things then that are not true today. So I think I do this so that we all have a healthy skepticism about the knowledge, the things that we know today. Because I call this, I like that, I like breaking that. I call it iconoclastophilia. That's a condition that I have. So iconoclast is somebody who likes to break down icons, and philia is you like that. So that's good. So you remember Don McLaughlin? Mm-hmm. Used to be Don Crapper. Dr. Crap. Do you remember what a name that was? That's why I changed it to McLaughlin. We had 3 neurologists who taught us medicine when I was in medical school. One was Don Crapper. The other was Phil Seaman. And then there was Les Organ. Those were 3 real guys. Les Organ, Phil Seaman, and Don Crapper all taught us neurology. We were taught that subjective cognitive impairment was depression. Remember I said if you say, the person says, my memory's shot, they're depressed, maybe not so fast. benign senescent forgetfulness isn't necessarily so benign. Pre-senile was the same as, and we thought that the mini mental state was the best cognitive screen. All of these things are wrong. So let's be a little skeptical. And here's another myth. Forever young. Look at me. That was me in 1974. You can see the ravages of aging, what they do to you. So that's another myth. So we have to prepare for the future, but in the end, this is the challenge. This is Sisyphus, and that's the challenge that we face with dementia. It's a big boulder that we're trying to roll uphill. And let's be realistic about the challenge. So to come back to the cascade and all the hope about curing dementia, I just put this on again to emphasize the bottom half of this, the care part. We all want the cure. We're all looking for the cure. The Alzheimer's Society and everybody, CIHR funding research that is going to try to find the cure, the genetic basis for Alzheimer's. But for the foreseeable future, we're going to have to care for a lot of people, a growing number of people with dementia who we cannot cure and who need care, whose families need support. It's going to cost our society a lot of money, and we still have to pay attention to the care part. So I thought I would end on that note. So I'm happy to stop there and entertain a few questions, if that's all right.
You didn't mention the effect of hormones.
Estrogen. I didn't mention it because there isn't any good evidence that it works. It is being studied, and there were some preliminary studies that thought that maybe estrogen would be protective. My colleague Mary Tierney at Sunnybrook is doing some studies on estrogen and dementia. But I think it's fair to say that as of today, there is no evidence that taking estrogen will prevent dementia or Alzheimer's. I'm sorry. And before anybody asks me, I can tell you the same about ginkgo biloba. I can tell you the same about these NSAIDs, the anti-inflammatory drugs. I can tell you the same about vitamin D, vitamin E, vitamin B, vitamin C, you name it, doesn't work. The one thing that is not pharmacological that does seem to be effective in the prevention of Alzheimer's disease
Blueberries.
is what?
Blueberries.
Blueberries. Well, all right, if it works for you, blueberries. Now, there is something that does seem to have an effect. In exercise. Physical exercise. Actually, more so than even mental exercise. Some evidence that keeping active probably just prevents the disease from manifesting itself as early as people who don't exercise their brains. That's why IQ, education are factors probably in brain reserve. It doesn't prevent the disease. But physical exercise, there is some evidence to support that. So it's good for the heart and it's good for the brain. Yes?
Is gender a factor in Alzheimer's?
Not really. Except that men die earlier. Yes?
So I guess we all sort of start to have more and more subjective complaints as we grow older. Are there particular warning signs that you think of more than others?
For Alzheimer's disease, you mean, specifically?
Yeah. Or, I mean, any sort of the transition, because, let's say, as we're growing older, more and more of us get to have these subjective cognitive effects. So, at what point do you think that becomes concern as opposed to?
Well, the evidence that I've shown you is that the subjective cognitive impairment that's related to memory is most predictive. So, if in fact the impairment is in memory, it's probably worth at least having a screening test. So, if you come to a physician and you say, "Doc, my memory is shot and I think I have Alzheimer's disease," and they do a screening test, the mini mental state or any of the other screening tests, and you're doing okay, that doesn't mean you don't have the disease, but at least you've got a baseline, which is very important. So when you come back a year later or 2 years later and you complain, there is an objective measure to compare to reassure you, look, you're doing the same as before, or no, I think there's been a deterioration, we're going to have to do more investigation. So at the very least, the baseline testing is of value. Yes?
significant is family history?
You know, I think, well, family history is almost always significant. It doesn't mean because you have a family history that you're going to get it, the disease, but it does, in almost all conditions in medicine, family history increases the risk. There's a general rule, I think, in genetics and family history that the earlier onset the disease, the more genetically determined it is. That's true of many diseases. Usually the more severe it is, early onset. So there is an autosomal dominant form of Alzheimer's disease which affects less than 10% of all Alzheimer patients. And it tends to be early onset. Most of the late onset diseases are sporadic cases, not necessarily genetically determined. But family history, you know, that woman I showed you whose mother had dementia, that was a red flag, you know. She had the same symptoms. She deserves attention, and sure enough, she had the disease. Yeah.
I just saw a study last week in the paper where they said that low vitamin B12 levels are connected with a smaller brain, like brain shrinkage. And you did mention brain shrinkage with dementia.
Well, it has been known that B12 deficiency could be potentially a cause of dementia. I'd have to say that that's still pretty rare. Very rarely do we see people who present with dementia that if they have a true vitamin B12 deficiency, it needs to be corrected. I don't think it's very common that you see a complete reversal of dementia in people like that. But yes, vitamin B12 and people who are anemic and have to be investigated for B12, particularly with a macrocytic type of anemia. It is one of the things, one of the potentially reversible causes. So there are all sorts of reversible causes of dementia, and again, that's why the primary care general practitioner is important. If there's a change in cognition, you probably should go to your family physician first. And as a psychiatrist, I'd want to know that a GP has done screening, and there isn't something going on in the brain, that there isn't something going on systemically that may be causing the change. So you really should, that's why primary care health teams, not just the GP, is important. Yes?
I have seen many elderly being prescribed Exelon patch. How does it work, or does it work?
Yeah, the Exelon patch is one of the cognitive enhancers. It's rivastigmine. And it's a patch that bypasses the gut in people who have stomach symptoms. It's absorbed through the skin, and it's what we call a cholinergic enhancer or an acetylcholinesterase inhibitor. We didn't talk about that really today, that in Alzheimer's disease there is a deficit in acetylcholine, it's a cholinergic deficit, and these so-called cognitive enhancers act by preventing the breakdown of acetylcholine. So that's how rivastigmine works, along with the other. There are 4 cognitive enhancers that are available today: donepezil, which is Aricept, rivastigmine, which is Exelon, galantamine, which is Remenil, and memantine, which is Ebixa. Those are the commercially available cognitive enhancers. They all pretty much work the same, equally well. It's hard to predict who's going to, but it's one of those cognitive enhancers that.
Do you recommend those when you?
Yes, I think the standard of care would be somebody who has dementia, not mild cognitive impairment, but dementia, is entitled to a trial, should be given a trial of a cognitive enhancer. They're not benign drugs. So I see we're going to lose our audience in a second. Any last question, burning question? Go ahead.
Yes, I have a question from one of our web attendees.
Oh.
Karen Henderson asks, what is the relationship, if any, between dementia and hoarding, and then depression and hoarding? Her 60-year-old neighbor is a hoarder, had an MRI and they found nothing, but she failed the clock test and can no longer drive.
Whoa. Well, if they fail the clock test. Hoarding is generally not associated with dementia per se. People who hoard, we don't find a high prevalence of dementia in that population. Some people think of it as actually an anxiety disorder more than a cognitive disorder. But, you know, the thing about dementia, what it does is it tends to exaggerate a lot of premorbid characteristics and personalities. So through disinhibition. So if you were a hoarder all your life, but you had it just barely under control, and then you develop dementia, well, maybe the hoarding will get worse for a while until you forget to hoard. But hoarding per se is not associated with dementia. More so with the depression, but again, I'm not an expert on hoarding, but I've seen enough that it's not like all hoarders have either depression or dementia. Hoarding is an entity in and of itself, very difficult to treat. So that's it. On that unhappy note, maybe we can end the discussion.
Okay. This is a very tiny gift.
Well, thank you.
Appreciate it.
Thank you very much.
And everybody in the Institute is now going to take a class.
Good. Thank you.
Start with you.
I think